integrated care in the NICU. He has published over 200 original papers, abstracts, review articles, book chapters, presented over 100 lectures in the national, international conferences and seminars. Dr. Alvaro will be presenting about the apnea, intermittent hypoxia, and inflammation in the preterm infants. What do they have in common? So let's welcome Dr. Alvaro.
It is an honor for me to present this lecture today, and I want to thank the organizers of the 6th International Neonatal Multispecialty Conference for allowing me to make this presentation today. So the title of my presentation is Apnea, Intermittent Hypoxic Events and Inflammation in Preterm Infants. What do they have in common? I have no conflicts of interest to declare. And for today's presentation, my objectives are following. First, to understand the definition and importance of intermittent hypoxic events in preterm infants. Second, to recognize the relationship among apnea, intermittent hypoxic events, and inflammation. Third, to understand the pathophysiologic mechanisms of apnea and intermittent hypoxic events. And finally, to describe the prevention and treatment of these intermittent hypoxic events. As you know, neonatology has changed and has progressed dramatically over the last 25 years or so. And nowadays, smaller and more immature and younger preemies, like this one that you see in this picture, not only survive, but they are extubated sooner than ever before, especially after the widespread use of prenatal steroids and the development of surfactant for the treatment of Hallen membrane disease. Now, keep these infants extubated and free of any short and long-term complication remains our main challenge. Now, we know that there are things that have been recognized and proven to improve outcome in these extreme preemies. Those things are being born in the hospital, inborn, to have received prenatal steroids, to receive early CPAP and surfactant. The use of caffeine has also improved outcome. The use of express breast milk, especially if it's fresh breast milk. The use of indomethacin prophylaxis to prevent severe grade 3 and grade 4 intraventricular hemorrhage. Delayed cord clamping, skin to skin or kangaroo care, and finally the social environment. Now, many of these things have been proven by clinical studies. Some others have not, but they make physiological sense. Improve. As a significant issue for bad outcome only in the last 10 or 15 years. So, and this is it's going to be to bad outcome that has only effect recently. So here is a picture of an iceberg, and this is what I use to teach the residents and fellows the relationship between apnea and intermittent hypoxic events. Here we have the tip of the iceberg, and this is what the bedside nurse sees at the bedside, and what she records in the bedside sheets when she detects an apnea by the monitor. But what she fails to show is everything that is under the water. This is the big piece of ice of this iceberg that what we call it intermittent hypoxic events. These are the events that unless you look for them, looking at the histogram, the daily histogram, you will miss. And you only be able to see what the nurses see in the big monitor, which is just a small portion of the big issue. So here we have a representative tracing of small preterm infants with a birth weight of 780 grams, a gestational age of 25 weeks, and a postnatal age of 26 days. Here on the top, we have the EKG signal. Here on the bottom, we have the nasal flow signal that shows inspiration when the line goes up, expiration when the line goes down, and when you see a flat line like this, there is a respiratory pause, there is no flow. So that means an apnea. Okay, as you can see, this baby is breathing periodically with intervals of breathing and apnea, And many people will consider this benign because it's very, very commonly seen in preterm infants. But if I show you exactly what's happening with this baby oxygen saturation on the bottom, you will see that there is nothing benign about this tracing. This baby significantly oscillate the saturations to the mid-high 90s when at the end of his breathing interval, but those saturations drop to the mid-high 70s and even lower at the end of each respiratory pause. We know that this respiratory instability and the need to stabilize oxygen has been recently recognized as a significant clinical problem. And the magnitude of this problem has been aggravated with the increased survival of extreme low birth weight infants. One of the ways that we have to assess the severity of the problem is looking at a daily histogram provided by the pulse oximetry that tell us how much time the infant spent on each oxygen saturation range over time. And here we have examples of two different histogram charts. On the left, in green, we have a baby that is breathing regularly and has good lungs, is in room air. And on the right, we have a preterm infant that has chronic lung disease and is breathing periodically. And as you can see, the baby on the left in green is spending most of the time with saturation above 90%, with only 5% of the time below 90. So this is a normal, very acceptable histogram. However, when you look at the histogram on the baby on the right in red, you will see that this baby spent way too much time with SATs below 90, 45% of the time below 90. And when you look at this, the amount of time this baby spent below 80 is 10% of the time. So this instability in the oxygen saturation and the percentage of time this baby spent hypoxic has been associated with significant short and long-term morbidity. So how can we define chronic intermittent hypoxemia? We can say that these are brief, repetitive cycles of decreases in hemoglobin oxygen saturation from a normoxic baseline, followed by reoxygenation and return to hypoxia. And this intermittent hypoxemia and reoxygenation has the potential to sustain a pro-inflammatory cascade that could result in multi-system morbidity. So today we're going to discuss about when does this problem with intermittent hypoxemia happens, why does it happen, what problem does it bring, and finally, how can we prevent it. So here's a study that was done in Cleveland by Dr. Di Fiore, the group of Richard Martin. They follow a group of preterm infants less than 29 weeks for the first 8 weeks of life, looking at the number of hypoxemic events that they define as events below 80% saturation and number per week. As you can see here, the number of these episodes is relatively low in the first 2 or 3 weeks of life, and start going up on the 3rd week, reach a plateau between 4 and 6 weeks before start declining after 6 weeks of age. Now, the reason for the low incidence of these hypoxemic events in the first 2 weeks of life is likely related to the decreased activity of the peripheral chemoreceptor that makes the breathing more regular, the fact that these lungs are still relatively unharmed, and the fact that these babies usually have a very high fetal hemoglobin that prevent these hypoxemic events. Now, the reason why these events significantly increase on the 3rd week of life is because now the lungs have been damaged by oxygen and mechanical ventilation. Many of these babies have been transfused with adult hemoglobin or has been slowly switching from fetal to adult hemoglobin physiologically, and also because the activity of the peripheral chemoreceptor now is not silent anymore, is increased, and that will contribute to unstable breathing pattern. And the reason why these events start dropping slowly after week 6 of life is likely related to the fact that the lungs are now recovering and the oxygenation start improving, and that makes the peripheral chemoreceptors activity go down, and that helps to regularize breathing. So the first question we ask ourselves is why preterm infants breathe periodically with apneas? Of course, we need to focus the problem first in the respiratory control system. Now, we know that for breathing to be regular, it has to be mostly regulated by the central chemoreceptors located in the brainstem, with very little contribution from the peripheral chemoreceptors located in the bifurcation of the carotid arteries. That will make the breathing stable and regular. And this is what happened in most adults, healthy adults at sea level. But what happened is this balance is reverted. Whenever you have most of the control of breathing coming from the peripheral chemoreceptors with less input from the central chemoreceptors, breathing becomes unstable. And this is what we think is happening in this preterm infant. The activity of the central chemoreceptor is decreased, and the activity of the peripheral chemoreceptors is significantly increased, which makes breathing very irregular and unstable. So the first problem with the respiratory control system is the fact that the central chemoreceptors located in the brainstem, the activity is decreased, and this has been proven by many studies done in the 70s and 80s here in our centers in Winnipeg, and by Dr. Pancalari in Miami, showing that the more preterm more preterm you are, the less sensitive the central chemoreceptors are. And when you compare babies with apneas and without apneas, the babies with apneas have significantly less sensitivity of the central chemoreceptor to CO2. The other problem these babies have with the respiratory control system, as I mentioned before, is the critical role of the increased activity of the peripheral chemoreceptor that makes this breathing unstable. Here is a diagram that shows the relationship between the arterial PO2 on the bottom and the carotid body impulses per second on the y-axis. As you can see here, when the PO2 is high, 90 to 100, which is usually the normal PO2 in adults, these carotid body receptors are silent and not very active. In term infants, the PO2 is slightly lower, usually between 70 and 80. So the activity of the peripheral chemoreceptor is slightly higher than adults. But see where these preterm infants are located. These preterm infants usually have a PO2 between 50, 60, and 70. And that's where the peripheral chemoreceptors become very, very sensitive. And that makes the activity of the receptors very high. That means that with little changes in PO2 that occurs in these babies with movements, feeding, crying, changes in sleep state will make the PO2 to oscillate between 50 and 70, and that will make this peripheral chemoreceptor to react or overreact significantly, and that will make breathing quite irregular. The other important problem with the respiratory control system is the critical role of the CO2 apneic threshold. This is the minimal PCO2 level that is essential to sustain breathing. When we look at the difference between baseline CO2 and threshold apneic CO2 in adults, that study was done by Dempsey and Young in the 90s, and showed that normal adults usually have a buffer between the baseline CO2 and this pre-periodic or apneic threshold CO2 of about 4.5 to 5 torrs. But when we measure the difference between baseline CO2 and apneic CO2 threshold in preterm infants and term infant, we found that that difference is only 1.5. So that will make definitely increase the predisposition to have apnea. And I'm going to explain why that is. So here we have a diagram showing on the top adult subjects. On the bottom we have neonates. And here we have a line that shows the normal variations of CO2 or baseline CO2. And the dotted line represents the apnea threshold CO2. And in adults, that difference is usually 4 torrs. Now in neonates, we have the same line, but now the difference between the baseline CO2 and the apneic threshold CO2 is only 1.5 torrs. So what happens in adults? The baseline CO2 never stays exactly the same. It will move up and down. It will oscillate, again, with feeding, crying, running, sleeping, changing sleep state. That CO2 will move up and down, okay? But because of that 4 torr buffering capacity, that CO2 will never go below the apnea threshold, and breathing will continue to be regular. However, in neonates, the same variations in CO2 with crying, changing sleep state, feeding, and so on, because that buffer is only 1.5, it will make that CO2 to fall below that apnea threshold. And every time that CO2 falls below the apnea threshold, then you will see a respiratory pause. Okay, and that explains why these babies breathe periodically most of the time. The fourth element that to the abnormal respiratory control system is the critical role of inflammation and infection. So it is well known that apnea increases in frequency and severity during acute infections in preterm infants. And premature infants are often exposed to infection and inflammation prior to birth and thereafter. So pro-inflammatory cytokines such as interleukin-1 beta and 6 and 2 necrotic factor produced during the acute phase of immune response to infection may serve as a key mediator for apnea, either directly or by release of prostaglandin E2. Now, not only these cytokines predispose to apneas during the acute infection phase, but may also alter the structure, the function, and the development of the central and peripheral chemoreceptors, predisposing these preterm infants to have persistent apneas beyond the acute phase of infection. Now, why some preterm infants desaturate so fast? When you and me stop breathing for a few seconds, our saturation doesn't change. We have good oxygen reserve in our lungs, and we don't desaturate. So what makes the desaturation to be fast and significant in somebody? So it depends a lot on several mechanisms. One is the pulmonary amount of pulmonary oxygen stores. Second is the pulmonary vascular function. Third is the total blood oxygen capacity. Fourth, the slope of the hemoglobin oxygen dissociation. And finally, it also depends on the tissue oxygen consumption. Of all these 5 factors, the ones that play the most important role in preterm infants that predisposes infants to desaturate very fast and significantly are the first 2, decreased pulmonary oxygen stores and abnormal pulmonary vascular function. So, so the problem is in these babies is also not only with the respiratory system, also problem with their lungs. Now, we know that preterm infants are particularly prone to inadequate inexpiratory lung volume due to excessive chest wall compliance, leading to distal airway closure and a profound and rapid fall in arterial oxygen desaturation during apnea. Now, activation of chest wall muscle substantially contribute to chest wall stability and help to maintain FRC, which is problematic as premature infants spend more than 80% of their sleep in active sleep, a sleep state that is associated with a tonic inhibition of chest wall muscle. So these preterm infants do not have the ability to compensate for that compliant chest wall. The other problem is inflammation and BPD. Now, the same pro-inflammatory cascade triggered by pre- and postnatal infection and inflammation that we mentioned before, affecting the development of the respiratory control, added to the harmful effect of mechanical ventilation and oxygen toxicity over the developing lung, produces significant lung injury and chronic lung disease. Now, this progressive inflammation also leads to more frequent and worsening intermittent hypoxic events. Now, the other important factor for the degree of desaturation in these premature infants is the abnormal pulmonary vascular function. Now, this inflammation also leads to arrest development of the airways and vasculature, leading to pulmonary hypertension and blunted hypoxic pulmonary vasoconstriction. And this altered pulmonary vascular function may also contribute to the rapid hypoxemia that develops during apnea in infants with chronic lung disease. Now, trying to put everything together, prematurity, inflammation, and infection impairs the respiratory control by altering the structure, development, and function of the central and peripheral chemoreceptors, either directly through the release of pro-inflammatory cytokines and indirectly through the increased production of prostaglandin A2. Now, this prematurity, inflammation, infection also leads to immature and injured lungs. Now, the combination of an abnormal respiratory control and abnormal lungs leads to chronic intermittent hypoxemia. Now, however, the cycle unfortunately doesn't end here. There is evidence that these chronic intermittent hypoxic events may also predispose to pro-inflammatory, pro-oxidant cascade. Most of our knowledge on this subject comes from animal studies and adult studies with obstructed sleep apnea. And we know that in those cases, intermittent hypoxemia is invariably associated with recovery to normoxia and sometimes hyperoxia if oxygen is used. And this in turn may cause oxidative stress with release of pro-inflammatory cytokines and inhibition of antioxidants enzymes. Now, it is difficult to differentiate between the pro-inflammatory effect of hypoxia versus the effect of oxidative stress associated with recovery to normoxia or hyperoxia. However, this pro-inflammatory and or pro-oxidant cascade in turn may further inhibit and alter respiratory control and produce more lung injury, aggravating the problem and closing the vicious cycle. Now, what clinical problems are associated with chronic intermittent hypoxemia? Now, most of this has been seen in animal studies, in adult studies that have shown an association between chronic intermittent hypoxemia and respiratory instability, altered growth and abnormal feeding, significant retinopathy of prematurity, altered cardiovascular regulation, and also abnormal neuromental outcome. So this is a study that was published in 2015. This was a post-hoc analysis of a large randomized controlled trial using two different goals for oxygenation from birth that has shown a strong association between intermittent hypoxemia or bradycardia and late death or disability in extremely preterm infants. Now, there's also another study that was published for the same group of Di Fiori in Cleveland that has shown a strong association between the number of desaturations per week and the severity of ROP. So here on the square black, we have babies that had severe ROP that were treated with laser. In the black triangles, we have babies that had ROP but did not require treatment because the ROP was mild. As you can see, when you look at the number of desaturations per week, the group that required laser, that has more severe ROP, has significantly more desaturation events compared to the group with milder ROP. So how do we treat or prevent these intermittent hypoxemic events? Now we know that if we target lower oxygen saturation, especially in infants with BPD, the risk of hypoxemic events will increase significantly. However, the ideal oxygen saturation range is not known. There have been several large randomized controlled trials that have compared two different oxygen saturation ranges from birth. Most of them use ranges between comparing 85 to 89 with 91 to 95% saturation. And this study has shown that the higher saturation range is associated with higher rates of ROP and BPD, while the lower saturation range may be associated with increased mortality and long-term morbidity. So try to determine the optimal level of arterial oxygenation that prevents chronic intermittent hypoxemia without increasing the risk of ROP remains a challenge to all of us. So it may be better to aim for lower saturations up to 32 to 34 weeks post-conceptional age to limit the suppression of normal retinal vascularization due to hyperoxia, and aim for slightly higher SATs thereafter to limit the retinal vascular overproliferation that is triggered by intermittent hypoxemia. Now, this approach still needs to be carefully considered and studied to determine if this is safe and effective before we can start implementing this approach. So what else can we do to prevent or treat these events? Well, we know that CPAP is extremely useful to stabilize breathing and improve oxygenation. The way CPAP works is by increasing functional residual capacity and oxygenation, by decreasing the resistance of the upper airway. Also helps to stabilize the rib cage and splint. We also know that another method that we have to prevent and treat this chronic intermittent hypoxemia is the use of caffeine. Now we know that caffeine stimulates respiratory centers and improves respiratory muscle function. And by doing that, what caffeine does is we will improve oxygenation. And by improving oxygenation, we'll make the peripheral chemoreceptor less active, and that will help to stabilize and regularize breathing. We also know that caffeine decreases hypoxic ventilatory depression by blocking adenosine, and by doing that, the activity of the central chemoreceptor will increase. So what caffeine is doing is try to restore the balance of breathing, having most of the control of breathing coming from the central chemoreceptor and significantly less control coming from the peripheral chemoreceptor will help to regularize. This is a study that was done by Dr. Rin in the States. They enrolled 95 infants less than 32 weeks in 16 NICUs in the States. And what they did is they looked at babies at 34 weeks after this baby had been off caffeine for at least a week. The neonatology had decided that these babies did not need caffeine anymore. So at 34 weeks, these babies were randomized to either continue to be off caffeine until 40 weeks, or they were automatically restarted on caffeine. And here we have the results of the two groups. The control group that remained off caffeine is in green, and the group that was restarted on caffeine is in red. And here we have the the time these babies spend below each saturation threshold. And as you can see, the number of time or the percentage of time these babies spend below 90, below 85, and below 80% saturation was significantly less in the caffeine group. So this study shows us that even though many times we believe this baby are ready to be off caffeine, many babies, that especially those that have chronic gland disease, may benefit from longer use of caffeine. And the way we know when a baby is ready or not is to follow the histograms. And every time we stop the caffeine, we should be following the histogram for at least 7 to 10 days after discontinuing caffeine, just to be sure that these babies do not have significant intermittent hypoxia. Going back to our diagram that I showed before, just to summarize, here on the top we have preterm infants in room air and without caffeine. As explained before, because of the narrow difference between the baseline PCO2 and the apnea threshold CO2, normal variations in baseline CO2 makes the CO2 go below the apnea threshold, and when that happens, babies will stop breathing and will become periodic. What happens when we give oxygen, or when we improve the oxygenation, or when we give caffeine? Now, we can change this small buffering capacity between the baseline CO2 and the apnea threshold, but what we do when we improve oxygenation and we give caffeine is we minimize the variation or the oscillations of that baseline PCO2, and we keep that baseline CO2 above the apnea threshold, and that makes breathing to be more regular. So in summary, chronic pulmonary inflammation added to respiratory instability are the main precipitants of chronic intermittent hypoxemia in preterm infants. Episodic hypoxemia reoxygenation promotes a pro-inflammatory, pro-oxidant cascade with adverse effects on multiple organ systems, including respiratory control, leading to short and long-term mortality and morbidity. And a better understanding of the underlying pathophysiology is needed to provide a rationale for preventing and or treating this episode. Thank you very much.